Alrighty. Thank you for joining us today. We're really excited to share an awesome modernization story that sits at the intersection of public health practice, harm reduction programs, and practical informatics implementations. This presentation focuses on how the Louisville Metro Department of Public Health and Wellness, or LMPHW for short, in partnership with Barry Dunn and other stakeholders, was able to move an anonymous syringe exchange tracking process from a largely manual and locally managed system environment into a more sustainable and purpose-built EHR based solution. At its core, this is a story about what it takes to modernize a highly sensitive public health workflow without losing sight of the overall mission that gives the work its true meaning and purpose. And the syringe exchange program is not simply just a data collection environment or a reporting function. It's a point of prevention, engagement, and in many cases, a point of trust for individuals who may face substantial barriers to care. That reality shaped the design challenge from the beginning. The team wasn't just trying to digitize an existing process, they were really trying to create a system that could support an anonymous process, strengthen operational usability, improve reporting and continuity, and fit within a larger modernization strategy at the agency level. And for that reason, this presentation is not only about the technology implementation, but it's also about how public health agencies can align system design with frontline practices, privacy obligations, and long-term infrastructure goals in settings where the modern service itself requires careful and thoughtful adaptations. So before we really dive into this topic, we want to be clear about what the audience should really take away from this session and why this case study matters beyond a single local implementation or a single program. By the end of this presentation, attendees should understand why the exchange program required a specialized and modernized approach rather than generic technology solutions. This includes appreciating the operational realities of anonymous participant tracking, the importance of protecting and developing that trust and confidentiality in a harm reduction setting, and the challenge of building a workflow that supports both frontline service delivery and meaningful public health reporting that gives those programs the data that it needs to be able to make informed decisions. We also want the audience to see how LMPHW was able to balance the anonymous nature of the work, the workflow, and the reporting needs inside a broader EHR strategy without losing sight of the mission of the program itself. Again, the harm reduction program is just one of many programs that LMPHW was bringing along to adopt a new EHR system. So it's understanding that careful balance between program-specific goals and how those fit within the larger digital transformation strategy of the organization. And finally, we hope attendees leave with the practical lessons that they can adapt to their own organizations, especially if they're working in sensitive, high trust or otherwise non-traditional service models where standard enterprise tools might not fit neatly within the program without thoughtful design, partnership, and decision making. So over the next 50 minutes or so, we're going to walk through not only what was built, why the work mattered, the conditions that were necessary to make the work happen, the challenges that had to be solved along the way, and then those lessons that might be useful for other public health agencies facing similar questions regarding modernization or digital transformation. Our goal is to make this session both useful as a case study and as a practical framework for thinking about how specialized public health programs can modernize their workflows and their operations without losing the qualities that make them effective. In that sense, this roadmap isn't just a review of topics. It's a way of showing how mission, operations, technology, and trust can intersect in real-world implementations, and how that can really elevate the work that public health agencies do. This is not simply a technology story. It's really a story about how public health programs evolve when their operating environment becomes more complex, The reporting needs become more sophisticated or change on a regular basis. Their privacy obligations become more important every day, and their staff need systems and technology that are able to support that service delivery rather than serve as a hindrance. This is also a story about what happens when a program reaches the point where legacy tools can no longer keep pace with the demands that are being placed on the work. In many organizations, modernization is described as a system replacement. Rather, here it is better understood as an effort to align the informational infrastructure with the actual realities of frontline service, public health accountability, and how that fits within a long term agency strategy. That broader framing is really important here because it helps explain why the design choices in this project were so consequential. So first, we're going to start with the broader organizational context at LMPHW, because it's really important to understand the agency as a whole and not only how the harm reduction program fits within that larger agency. And that helps to understand some of the nuances to this project and how this is more complex than just a simple database or technology replacement effort. LMPHW's mission includes advancing health equity and improving community health outcomes, which means technology decisions have to support not only the documentation and reporting and workflows, but also that access, trust, and effective service delivery as it pertains to engaging with the public, especially vulnerable or at-risk populations. From there, we'll look at the Syringe exchange program's early paper-based workflows and a subsequent move to a Microsoft Access database so that the audience can understand not only the evolution of the program, but see how the operational constraints at every step of the way that staff were facing help to kind of inform and lead us to this moment before we were able to adopt a modern solution. We will then step back and discuss the public health and harm reduction context that's shaped the program's needs. Again, because the logic of the service models is central to understanding why a generic or one size fits all approach would not have been sufficient. After that, we will spend substantial time on the design and development of the new system, including requirements, privacy protections, data migration, workflow alignment, and implementation realities, and how the organization navigated some of those decisions. And then we'll close it out by examining the benefits realized and the broader lessons learned from this work and how that aligns with some of the other topics that you might learn about at the conference and how that aligns with some of the other concepts around public health infrastructure, technology modernization, analytics, and specialized program design. These lessons are relevant not only because the project was successful, but because it illustrates a set of tensions that many agencies are now facing. How to modernize legacy tools, protect confidentiality in sensitive settings, and how to support staff with better workflow design and create systems that are both useful in practice, but also sustainable over a long-term future. Our hope is that by the end of this presentation, the audience will come away with practical insights into how to approach modernization and digital transformation efforts in settings where confidentiality, trust, operational usability, and data-driven management all have to be balanced at the same time, especially within the broader context of department or agency-wide initiatives and strategy. We also hope that the audience leaves with a clearer sense of effective public health informatics work and how that begins with understanding the program itself and its needs, and then building the technology or pursuing technology changes based around that reality, rather than necessarily forcing a program to conform to a tool that was never necessarily designed to meet those needs in the first place. So first, want to begin with the organizational setting. The Louisville Metro Department of Public Health and Wellness, or LMPHW, is the public health agency serving Louisville, Kentucky, and Jefferson County in its mission to protect and improve the lives of the community using innovative solutions and collaborative partnerships. This distinction is important because it changes how we should think about a project like this. Many organizations' technology efforts are framed primarily as operational upgrades, compliance activities, or efficiency improvements, which are all important, certainly. At LMPHW, however, the backdrop is broader and more mission driven. The agency's work is rooted in the idea that health is shaped not only by clinical care, but also by access, trust, prevention, lived conditions, and the structural factors that influence who can realistically benefit from services and who remains excluded from them or face higher barriers to access. LMPHW believes that health equity is core to its mission and woven through its decisions and daily operations, which helps explain why technology design in this setting cannot be separated from the public health purpose. The agency is working within a public health model that is explicitly concerned with health disparities, access, prevention, trust, and outcomes. That means that any system supporting direct services must do more than store data or satisfy documentation requirements or compliance requirements. It needs to support the way that public health is actually practiced in environments where service delivery, outreach, prevention, and community trust are really core pillars of the work and are all closely intertwined. LMPHW is organized across major areas, including health operations, health services, and the Center for Health Equity, together supporting a mix of population level public health functions as well as direct service programs. In practical terms, this means that the agency must manage very different kinds of work at once: community facing prevention efforts, clinic and specialty services, environmental and preparedness responsibilities, an equity focused strategy that really addresses all of these different facets. A technology solution introduced into that environment has to fit not just one isolated workflow, but a broader ecosystem of services and programs, reporting expectations, and institutional priorities. And that is why the organizational context matters so much for the modernization story that we are telling today. And that broader mission context is the reason why we need to pause next on harm reduction itself, because the program that we're discussing only makes full sense if we understand the public health philosophy behind it. The Syringe exchange program was not operating on the margins of the agency's mission, it was an expression of that mission in practice. And to understand why the anonymous nature of the work, trust, and service design became such central concerns in the technology work, we need to first understand the harm reduction model that shaped the program's purpose and the population that it was intended to serve. So building on that organizational wide context, again, it's important to take a step back and talk about the public health purpose of the program itself. The Syringe Exchange program exists within a broader harm reduction framework, and that framework is essential to understanding why the workflow, privacy requirements, and system design in this project were so distinctive. Harm reduction is often misunderstood when discussed abstractly, so it is worth being very clear here. Harm reduction is a practical, evidence-informed public health approach focused on reducing the negative consequences associated with substance use while preserving dignity, reducing barriers to engagement, and connecting people to additional services. National public health guidance describes syringe services programs as community-based prevention programs that expand access to harm reduction services, reduce infectious disease transmission and other complications of injection drug use, and are able to connect people to additional health services such as testing, vaccination, and treatment referrals. Syringe services programs are associated with substantial reductions in HIV and hepatitis C incidences and are widely recognized as safe, effective, and cost saving when implemented comprehensively. It's not a narrow intervention. It's not necessarily just about the supplies. It's about reducing the overall risk, preventing infectious disease transmission, creating trusted points of contact, and building opportunities for people to engage with care and support systems over time. And that matters because many people serve through harm reduction programs experience barriers that make traditional service pathways difficult to access consistently, whether those barriers involve stigma, unstable circumstances, prior negative experiences with institutions, or fear that seeking help may expose them to judgment or a loss of privacy. In that setting, the program becomes more than a place where supplies are distributed. It becomes a low barrier entry point into a broader continuum of care and public health support. At LMPHW, this work sits within health services and includes the Syringe Exchange Program, harm reduction outreach services, and connections to related programs such as infectious disease prevention and the medication oriented recovery and enhancement, otherwise known as the MORE Center. This result is an ecosystem of prevention, treatment linkage, outreach, and direct service delivery rather than just multiple standalone intervention practices and programs. So, framing the program in that broader context hopefully is going to help the audience see why trust, anonymity, and continuity were not only secondary design considerations into the technology work, but they were central to the overall public health function of the program itself. And from there, the next question becomes what this syringe exchange program is actually doing in practical public health terms. In practical terms, the program's role includes reducing transmission of HIV, hepatitis C, and other bloodborne infections by providing sterile syringes, safe disposal options, education, screening support, and referrals to treatment or additional care when appropriate. National public health guidance recognizes syringe exchange programs as community-based prevention programs that not only reduce infectious disease transmission, but also create pathways to other forms of treatment, testing, vaccination, or other services that might otherwise remain out of reach for many participants. From a public health perspective, this makes the program both a prevention strategy as well as an engagement strategy. It improves safety at the individual level by lowering immediate exposure risks and supporting safer practices, but it also serves broader community health goals by reducing the likelihood of downstream complications and by creating repeated opportunities to connect with people, to care over time, and building those trusted relationships. That engagement dimension is especially important because many participants may not consistently access traditional healthcare settings, yet they may still build trust through recurring contact in lower barrier and no judgment environments. In that sense, the program is not only preventing disease, but it's also creating practical points of entry into a wider continuum of care and support. And once we see the program in that way, it's going to become easier to understand why its place within the larger LMPHW service environment matters so much, because it is that much more aligned in carrying out the organization's mission. So, where the syringe exchange program fits in LMPHW, the broader role is why, for today's presentation, the most relevant division in health services, because that is where the syringe exchange program sits alongside other direct services and prevention-oriented programs such as the tuberculosis services, infection disease services, women, infant, and children, or WIC programs, specialty clinic services, substance use related services, and the MORE program that we referenced earlier in this presentation. This organizational placement matters because it shows that the syringe exchange program is not operating as a standalone initiative on the edge of the agency, but rather it is embedded in a branch of LMPHW that already manages a wide range of public-facing direct programs that require coordination, documentation, service continuity, and accountability. In other words, the program is part of a broader service delivery environment where information needs were already interconnected, even if the systems supporting those programs were not yet fully aligned with that goal. That setting helps to explain why modernization pressures were not just local to singular workflows, but part of a larger operational context across health services. We want to pause here because that context matters for a couple reasons. Both of them help to frame the rest of this participation. First, the syringe exchange program is not isolated. It's part of a broader service environment where multiple operational, reporting, and coordination needs exist, which means the information challenges facing the program were never only about a single database, a single reporting workflow, or a single program. Second, LMPHW itself was already thinking about modernization on a larger scale, not just within one singular program. And as an independent academic public health department across health operations, health services, and the Center for Health Equity, the agency was operating in an environment where infrastructure decisions increasingly had implications beyond any one service line. That larger context created both an opportunity and a necessity. It created an opportunity to bring highly specialized workflows into a stronger long-term environment, and it created a necessity because leaving the program in a disconnected legacy solution would have become increasingly difficult to justify over time. The opportunity was to avoid building yet another disconnected solution, and the necessity was that legacy tools were no longer adequate for the level of coordination, reporting, privacy protection, and security that the agency needed as its broader modernization work advanced. Another important point is that public health departments often must manage a wider diversity of workflows than people really are able to understand or see from a public perspective. In one part of the organization, staff may focus on inspections, environmental health, or laboratory functions, but in another, they may be focused on direct clinical care, maternal and child health, tuberculosis services, or infection disease prevention. In another, they may be working on community outreach, prevention, behavioral health, or health equity initiatives that depend on trust and flexible service delivery. The systems that support these functions can't always be a one size fits all, and in many cases they aren't, because the underlying service models, data sensitivities, and operational expectations can differ substantially. That is exactly why this project is so interesting, because it sits at that intersection of that diversity. It's a highly specialized workflow with unique confidentiality needs, but it's also one that has to live within a broader organizational ecosystem that was moving towards more sustainable infrastructure and better analytic capabilities. The syringe exchange program had highly specialized requirements, especially around the anonymous nature of the work and sensitive population data, but it also needed to fit within the broader architecture of the evolving public health EHR environment. That meant that the project team had to solve two problems in the same initiative at the same time: preserve the logic and trust of harm reduction practices, and also position the program within a more maintainable, governable, and scalable agency infrastructure. So as you listen to the rest of the presentation, it may be helpful to keep one framing idea in mind. This project was actually about aligning a specialized harm reduction workflow within a larger agency mission and infrastructure strategy. And that alignment is what made the work both challenging as well as valuable. It required the team to think beyond whether a tool can simply capture the data adequately and instead ask whether the system can support the real world relationship building between confidentiality, service delivery, reporting, and long term organizational stability. So, with that more specific harm reduction context in mind, the operational history becomes a lot more easy to understand. The next part of the story is the journey from paper to a Microsoft Access database. And this is where the practical reality of supporting the mission becomes very clear. So, for just a little bit of context, LMPHW's Syringe Exchange Program was approved in May of 2015 and formally launched in June of 2015. In those early years, the program relied heavily on paper-based documentation to record participant visits, services, and other basic operational activity. This isn't unusual for new public health programs that are starting up, with limited infrastructure, but it created a workflow in which the immediate work of service delivery and the later work of documentation were closely linked, but not fully synchronized yet. So, in other words, the program is already carrying a significant information burden from the beginning. Staff were not only meeting people where they were in delivering harm reduction services, but they were also trying to create enough structure around those encounters to support reporting, continuity, and program management in an environment that had very little built in technology support. Because the program operates anonymously, staff cannot use a traditional patient registration process or rely on the kinds of standard identifying fields that a lot of health systems utilize, also take for granted. Instead, they had to manually assign and record anonymous participant identifiers in a way that preserved continuity over time without compromising the privacy that's so important to the nature of the work. That meant that the workflow involved not only service delivery, but also careful handling of identity protection at every step, from initial contact through documentation, and then additional reporting down the road. So, frontline staff completed paper forms during or after encounters, often while balancing the practical realities of a busy service environment, participant flow, and the need to keep the interaction supportive and engaging and low barrier. These records were later transferred into electronic tools for reporting and operational purposes, which added another layer of manual effort and another opportunity for delay or inconsistency. So, even at this early stage, as the program was establishing itself in beginning operations, the documentation workflow was already something that was quite demanding. It was trying to support anonymity, continuity, and public health reporting at the same time, using processes and documentation that were largely manual, heavily dependent on staff diligent and paper based. At one point, electronic reporting support included tools such as SurveyMonkey, and there are other attempts to use different pieces of isolated technology using mechanisms like Scantron forms. These efforts are worth mentioning because they show that staff and leadership weren't ignoring the problem. They were trying to create more structure and make reporting easier within the limitations of the environment that they had. But even with those adaptations, the core challenges remained. Data still did not become available quickly enough to support timely operational awareness and decision making. Manual transcription still introduced delays between what happened in the field and what could be seen in the reporting environment. Human error remained an ever present concern because the workflow still depended on multiple handoffs, duplicate handling, and later interpretation of handwritten or manually entered information. Leadership and frontline teams still had limited real time visibility into what was happening across the program. And probably the most important is that staff still had no practical way to view participant history in real time, which limited continuity in conversations, referrals, and service coordination. So, in other words, these might have been useful workarounds, but they weren't true workflow solutions that were going to be sustainable over any long term period of time. So, if we think about that in practical terms, it means staff were doing the hard work of harm reduction in an environment where the information system was always lagging in the care environment. That gap matters significantly, and not only because it makes reporting harder, it affects confidence in the data because when information arrives late or depends on repeated transcription or manual handoffs, people naturally become less certain that what they're seeing fully reflects the reality of the work or the program. It affects the ability to identify trends because program leaders cannot easily distinguish between what is emerging now and what is simply appearing late in the data. It can affect operational response because staff and managers have less ability to adjust quickly based on service patterns, supply needs, referral activity, or participation engagement across multiple encounters. And it affects continuity at the point of service because without timely access to prior history, staff may miss opportunities to build on earlier connections, reinforce referrals, or better understand what support systems a participant may have already received or what they may need. So the issue was not just that paper was inefficient, it was that the program had reached a point where information delay was beginning to interfere with the full potential of the care and public health work itself. So with that, I'm going to turn it over to my colleague Dennis to talk about the story of moving to Microsoft Access, and then future, sustainable workflow tools.
Thank you, Corey. In May of 2018, the program moved from that paper-dominant environment into a custom Microsoft Access front-end database with a SQL or SQL Server backend. This was a major improvement at the time, and it is important to say that clearly because the move represented a real maturation of the program's informational environment. For the first time, staff had a more structured way to enter data closer to the point of service and retrieve it without waiting for later transcription cycles. The system introduced validation rules and more standardized data capture, which helped reduce some of the inconsistency and ambiguity that naturally accumulates in manual workflows. It also made historical transactions more visible to staff, which meant the program was better positioned to support continuity across encounters, respond to operational questions more quickly, and to produce more reliable reporting for leadership and stakeholders. Just as importantly, the Access solution helped demonstrate the practical value of a digitalization in a way that paper never could. It gave staff and leadership a more concrete experience of what structured data, faster retrieval, and better historical visibility could mean for day-to-day operations and program management. In many ways, Access was that bridge between a manual past and a more modern future, but it was also a transitional solution. The same system that solved immediate problems also surfaced longer-term limits. Security controls were not as strong as the broader environment required. Maintenance could be cumbersome. Changes to the system often depended on one technically knowledgeable individual. Updating the front end across devices created operational disruption and version control risk. And partnership of Access was constrained by metro-hosted infrastructure and equipment requirements. And even though the system was better than paper, it remained a relatively isolated solution in a broader environment that was increasingly moving toward integration, standardization, and an enterprise-grade reporting. So when we describe the movement from paper to Access, we should not describe it as a failure or as an interim detour. It was an important stage of maturity in the program's evolution and one of those meaningful steps toward a more modern information environment. It addressed immediate pain points, demonstrated the value of digitalization, and it helped clarify what next generation solution would need to do. It also helped the organization move from a theory to more practice. Public health staff were no longer just saying that better data would help. They now had enough experience and access to specifically see how structured data, historical visibility, and better reporting could support the work. That experience made the case for the next phase much more concrete and credible because it gave staff and leadership a shared reference of what they had improved and what still need to be resolved in their issues. At the same time, the experience also exposed the limits of a locally maintained solution. Access improved the workflow, but it could not fully solve the broader issues of security, maintainability, governed access, partner connectivity, version control, and enterprise alignment that became more important as the program matured and the agency's overall modernization strategy advanced. In that sense, Access did exactly what an important transitional solution should do. It created measurable progress, built organizational confidence, and revealed the gap between a local tool, which was better, and a truly sustainable long-term platform. That is why this slide is less about criticizing Access and more about explaining why success at one stage can create the clarity that is needed for the next stage of modernization. This context matters enormously for system design. In many standard clinical workflows, technology assumes a known patient, a conventional registration process, and a record that can be linked across routine care settings in a traditional way. That model does not map neatly into a syringe exchange program, though, which operates with anonymous participant tracking. In this setting, anonymity is not a convenience, a feature, or a preferred layer on top of an otherwise standard workflow. Instead, it is a core requirement for trust, participation, and program integrity. If participants or patients do not believe their privacy will be protected, the barrier to accessing services becomes much higher, and the program risks undermining the very public health goals it is meant to advance. So, from the beginning, modernization was never just about replacing older tools. It was also about building an information environment that could preserve confidentiality in practice, not just in policy, and while supporting continuity, reporting, and operational usefulness. So the system challenge here was unusual and highly instructive. The program needed to know enough to support longitudinal tracking, continuity, reporting, and quality improvement, but yet it had to do so without undermining that anonymous nature that makes the service accessible. That created a design tension that is easy to state, but it was much harder to solve in real life. The system needed to preserve enough structure to make participant history useful across encounters, produce enough consistency to support trend analysis and management insight, and also develop enough accountability to support reporting to leadership and partners. At the same time, it could not introduce the kinds of conventional identity assumptions that would make the workflow feel more like a standard patient registration than a harm reduction outreach. In parallel, the program needed to document encounters, understand supply utilization, analyze trends, and support operational decision making. But it also needed to do those things in a way that was practical for staff working in real service environments, where usability, speed, and trust all matter at that point of interaction. So the harm reduction context is what gave this technology project its shape. It explained why the solution could not simply be a generic registration form placed into a standard electronic health record. So it also explained why the project had to be designed in partnership with the people who actually delivered a service, because frontline workflow knowledge was essential to getting the balance right. Technology had to respect the logic of harm reduction practice. It also had to support trust, not erode it, support outreach, not constrain it, and support public health insight without compromising the confidentiality of the population being served. But differently, the modernization drivers were not only technical pressures such as aging tools or reporting limitations, they were also mission pressures, service model pressures, and organizational pressures. The agency needed a system that could honor the realities of a specialized program while also fitting into a much broader modernization strategy built around security, sustainability, and better enterprise reporting. And for conference audiences, we think this is one of the most transferable lessons from the project. The best informatics solutions in public health are built when we start not with the software, but with the service model, the population needs, and the realities of the frontline work. What the new system had to do, we come now to the heart of the presentation, and that's the development of the new system. Up to this point, we have been building the case for why a specialized solution was necessary. This is the point where the case turns into a concrete design requirements. In many modernization efforts, the requirements phase is where a project shifts from a broad vision into a practical decision about what the system must actually do, what it must protect, and what trade-offs it cannot afford to make. For this project, that moment was especially important because the team was not designing for a standard clinical workflow. They were designing for a sensitive public health service model that depended on anonymousness, continuity, operational usability, and stronger reporting all at once. That combination is what made the requirements work so consequential. This work did not happen in isolation. It emerged from the broader EHR modernization effort at LMPHW, and that larger initiative created the strategic opening that made a new approach possible. Barry Dunn's professional services were sought out in August of 2021 to assist with selection of a public health encompassing electronic health record. And by January of 23, Medicalistics and NextGen have been selected as the new EHR vendor and platform approach. Barry Dunn continued in a project management and implementation support role as the agency moved into build and deployment activities. And that timeline matters because it shows the Syringe exchange solution was not conceived as a disconnected side project. It was being shaped inside a larger effort to modernize infrastructure, strengthen governance, and move toward a more sustainable long-term platform. In that sense, the project benefited from a broader organizational momentum that was already pushing the agency to ask more strategic questions about how specialized workflows should live within their future environment. That larger modernization effort mattered because it created the framework in which the Syringe exchange solution could be reimagined. Rather than leaving the program in a separate locally maintained database indefinitely, the project team had that chance to ask a more strategic question. How can we preserve the unique needs of that Syringe exchange program while bringing it into a stronger, more scalable, and more secure EHR environment? And that question is what drove the design process. And it's worth lingering on because it captures the central tension of the whole project. The goal was not simply to move existing fields from one system to the other. The goal was to rethink the workflow in a way that protected what made the program effective while also addressing the weaknesses of that original environment. That required the team to think simultaneously about privacy, usability, continuity, infrastructure, analytics, and long-term maintainability. It also required them to resist the temptation to treat specialization and standardization as opposites. The real challenge was to design a solution that could honor the program's exceptional needs while still fitting within the logic of an enterprise platform. Early in the work, the selection and implementation team, with the support from Barry Dunn, identified that the Syringe exchange workflow could not simply be absorbed into a generic EHR structure. The program needed anonymous participant tracking. It needed separation from the main patient registry. It needed to document encounters in a way that reflected actual program operations. It needed a stronger demographic data capture to support health equity analysis and program evaluation. It also needed inventory and supply tracking tied more closely to service activity. It needed reporting capabilities that could move beyond static record keeping and support actual program intelligence. And yet it also needed all of that while preserving trust and usability for the staff working across multiple locations and their service settings. You could put it another way, the requirements were both technical and operational. They were technical because the system needed specific capabilities and safeguards, but they were also operational because the workflow had to feel natural enough that the staff could use it consistently in their real service environments without disrupting the low barrier nature of the program. That is why this slide here is such an important turning point in the story. It shows that the new system was defined not by abstract software features, but by a carefully articulated set of real-world needs that arose directly from the public health function of the program and directly from its users. In other words, this is not an off-the-shelf configuration problem. It required a purpose-built module, and the development process reflected that reality from the beginning. Rather than moving directly into the build, the team worked through a set of practical and interdependent stages designed to reduce risk, clarify the workflow, and to make sure the broader solution would be sustainable inside that EHR environment. There was a current state assessment and a gap analysis that was performed. The team reviewed the legacy environment, including the access system and the surrounding workflow realities, to identify what was working, what was missing, and what risk would need to be addressed. That included not only the mechanics of data entry and reporting, but also the less visible issues of privacy handling, operational workarounds, partner access, maintenance burden, and the overall fit between the existing solution and the agency's modernization direction. These were also the requirements definition and the future state design. This is where the collaboration among public health staff, informatics specialists, implementation partners, and the vendor became very important. It is one thing to say that the program needs anonymity. It is another to translate that into an actual system design that supports registration logic, restricted access, reporting, and historical continuity. It is one thing to recognize that the workflow is specialized. It is another to determine exactly how encounters should be documented, how participant history should be surfaced, how inventory should be managed, and how reporting should work without making the system burdensome for the staff. And then there was data mapping and conversion planning. That work was not only technical, it also required agreement on how legacy information would relate to future state structure, which historical elements needed to be preserved, which assumptions from the prior system should be retained or which should be changed, and how to reduce the risk that modernization would create a break in the program's operational memory. Across all of these stages, the partnership model mattered as much as the technical plan. Public health staff brought their deep knowledge of service delivery and participant realities. Barry Dunn contributed workflow analysis, project structure, and implementation support. And the vendor brought forth their platform capabilities and build expertise. And broader agency context then shaped governance, security expectations, and long-term integration goals. The strength of the development process was that these perspectives were not treated as separate work streams. They were all brought together to solve a common design problem. And that is an important lesson in itself. In a project like this, partnership is not a supporting feature of implementation. It is a major part of the method of implementation. The legacy system contained more than 1,600 records that needed to be preserved and migrated through SQL-based conversion methods. And that worked far more important than a simple technical transfer. In a project like this, data migration is really about continuity of the participant history, of program memory, of reporting, and of organizational understanding. Modernization in public health cannot come at the cost of losing its history because historical data is not just archival. It helps staff understand patterns over time, supports trend analysis and performance insight, preserves the operational memory of the program, and reduces the risk that the new environment will begin with a partial or distorted picture of what came before. That was especially important here because the Syringe exchange program depended on anonymous identifiers and longitudinal understanding, which meant historical records carried practical value for continuity as well as analytic value for management and reporting. At the same time, migration had to be handled carefully so that the logic of the old environment could be translated into the structure of the new one without introducing any confusion or breaking trust in the data that's already been there. That is why data mapping and conversion planning were such an important earlier step in the process. The point was not simply to move the records, it was to carry forward usable, reliable history into a more sustained platform. In parallel, there was a build and a configuration. The new module had to support anonymous identifiers, logical data separation, encounter tracking, program services, demographic capture, and inventory management. It also had to align with the broader EHR environment so that the system could be maintained, secured, and governed sustainably over its lifespan. So this is really about one core idea. Modernization succeeds not only when the future state system is well designed, but also when the transition preserves enough of the past to keep the program coherent over time. Even the best design, though, can fall if users are not prepared, workflows are not aligned, and operational realities are not addressed. That is why validation, implementation readiness, and adoption support were so essential to the parts of the project. In a setting like this, implementation is not simply the moment when the system is turned on. It is the point at which a technical design meets daily practice, and that meeting point is where many otherwise promising projects can succeed or struggle or even fail. Multi-location service delivery, staff adaptation, workflow standardization, and coordination across teams all had to be part of that implementation approach. Staff needed to understand not only how to use that new module, but also how the design workflow would function in real service settings, how privacy expectations could be maintained, and how the system would support continuity without slowing down the low barrier nature of the program. Validation mattered because the team had to confirm that the module worked the way the program actually worked, not just the way it had been designed on paper. Readiness mattered because the go-live success depended on preparation across people, process, and technology. And adoption support mattered because sustainable implementation requirement reinforced troubleshooting and adjustment as staff incorporated the new workflow into routine operations. So this is really about one core point. Implementation was not a final step after the real work was done. It was part of the real work of modernization itself. We think one of the most important lessons in this development story is that the team did not treat customization as the opposite of standardization. Instead, they aimed for the right balance between the two. The syringe exchange module needed to be specialized because the workflow was specialized, but it also needed to live inside a more standardized and sustainable environment. That balance is often where public health modernization succeeds or fails. If the solution was too generic, it does not fit the work. If it was too isolated, it becomes hard to maintain and scale. This project tried to solve both problems at once. And yet another key lesson is that the development was not just technical, it was also organizational. The team had to coordinate business process understanding, public health practice knowledge, technology design, data conversion, governance, and change management. And that kind of interdisciplinary collaboration is not an optional work like in work like this. It is the actual work. And in many ways, that is why the resulting system is valuable. It was built through sustained alignment between program reality and technical design rather than through a purely abstract software exercise. Once the new system was in place, the benefits became visible across multiple dimensions. The first layer is in privacy and confidentiality. For a harm reduction program serving as an anonymous population, privacy is central to participation and trust. By standardizing the anonymous participant tracking and appropriately separating syringe exchange records within the EHR environment, the system created a stronger and more reliable privacy structure than the legacy workflow could support. And that matters for participants because trust is easier to sustain when protections are built into workflow itself rather than dependent or improvised local practices. It also maintains for staff and program governance because it maintains those clearer boundaries and more consistent system behavior supports sustainable, which is oversight, role clarity, and confidence that confidentiality is protected in practice as well in principle. The second layer is reporting and analytics. Under the old environment, reporting was limited and often lagged behind operations, making it harder for leaders and programs staff to understand what was happening in a timely or actionable way. In the new environment, the program is a much better position to generate useful information, evaluate activity, identify trends, and share appropriate partners with reporting. LMPHW is still refining reporting components to capture historical, current, and future quantitative and qualitative analysis, but the underlying shift is already significant. Data is now moving from passive documentation toward active decision support, and that's giving leaders and program managers a stronger basis for assessing outcomes, understanding the service utilization, and also to communicate program value with greater credibility. And then the third layer is integration and coordination. One of the recurring issues in legacy public health environments is that of fragmentation. Data is in one place, workflows are in another, and program knowledge distributed across individuals rather than systems. This new solution helps reduce the fragmentation by aligning syringe exchange activity more effectively with those broader health services environment. That does not mean that every boundary, though, has disappeared, nor should it, given privacy requirements, but it does mean that the program is less isolated from the agency's overall operational and analytic infrastructure. In practical terms, this supports better coordination across teams, creates a stronger foundation for shared reporting and governance, and it also reduces dependence on disconnected local workarounds that are difficult to maintain over time. Integration here is not about making the program less specialized. It is about making the specialized workflow more sustainable within the larger organization. The fourth layer of benefits that were realized is data quality and workflow standardization. The old system improved on paper, but it still carried a risk of manual workarounds, local variation, and maintenance challenges. The new system now creates a more structured environment for encounter documentation, demographic capture, and service tracking, supported by clearer fields, more consistent processes, and fewer opportunities for information to be handled differently across staff, sites, and situations. That improves consistency and reduces duplication and errors, but it also makes the workflow more teachable, repeatable, and sustainable. In public health programs where staff turnover, onboarding cross coverage, and multi-site delivery are real factors, standardization is also a part of organizational resilience because it reduces dependence on individualized workarounds and tactic local knowledge. The fifth layer is operational efficiency or continuity. Staff needs systems that help them do the work rather than create extra work around the work. In the legacy environment, staff still had to spend time chasing information, reconciling disconnected tools, re-entering or verifying data, and working around version control or maintenance issues that were outside the program's public health mission. The new module supports encounter tracking, inventory and supply management, and access to historical information in ways that better match daily program operations. That means staff can move more directly from service delivery to documentation to operational awareness with less friction in between, while managers and program leaders gain a stronger basis for understanding what is happening without depending on delayed or fragmented information flows. Efficiency in this setting is not just about saving minutes. It's about reducing operational and avoidable drag so more staff time and attention can stay focused on participant service, continuity, and the program improvement. The sixth layer is scalability and resilience. The Access database was important as a milestone, but it had practical limitations as the program matured. The new platform now provides a stronger foundation for growth, more maintainable infrastructure, and better alignment with the long-term agency modernization goals. It also introduces a different kind of resilience because the system is no longer defined by a locally maintained tool with narrow maintenance pathways and limited adaptability. Instead, it now sits with a broader environment that is easier to govern, support over time, and evolve as program requirements, reporting expectations, and operational realities change. One of the biggest benefits is not only that the system is better suited to current operations, but it is now better positioned to absorb future change without forcing the program back into any disconnected workarounds or another standalone solution. Finally, continuity is that benefit in its own right, because it's easy to overlook when modernization is discussed only in technical terms. That migration of more than 1,600 legacy records through SQL-based conversion helped preserve historical information and reduce the risk of modernization would create a break between past and present operations. In public health, continuity matters for trend analysis, operational memory, trust in data, and understanding how programs evolve over time. When history is well preserved, modernization feels less like a rupture and more like an evolution. Taken together, the realized benefits include stronger privacy, better reporting, improved workflow support, more consistent data, and stronger coordination, greater operational efficiency, and a more durable platform for the future. In closing, the project demonstrates what can happen when focused research, practical workflow analysis, and thoughtful partnership are brought together in service of a real public health need. Ellen PHW and Barry Dunn did not simply replace a legacy database with a newer piece of software. They worked through a more important challenge, and that was how to modernize a sensitive, highly specialized harm reduction workflow in a way that protects the anonymous nature, improves operational usability, preserves historical continuity, and expands the organization's ability to learn from its own data. That combination is what makes the work relevant beyond a single local implementation. It shows that modernization in public health is most meaningful when it is not treated as an IT exercise alone, but as a deliberate effort to align technology with mission, service delivery, trust, and long-term organizational capacity. In that sense, the value of this project is not only that of a better system that was built, it is that process of building it clarified how thoughtful informatics design can strengthen a public health program without asking that program to get up the qualities that made it effective in the first place. And there are many agencies that are dealing with fragmented systems, locally maintained tools, reporting limitations, and specialized workflows which do not fit neatly into a standard enterprise platform. This project offers a concrete example of how those tensions can be addressed, but more importantly, it offers a way of thinking about the program. The answer is not to choose between customization and sustainability, or between program specificity and enterprise alignment, as though those were mutually exclusive options. The real work is to determine which aspects of a workflow are essential to preserve, which constraints are creating unnecessary burden, and how a future state design can respect both program reality and broader organizational needs. That is why this story has broader value for conference audiences. It reflects the challenge that many health agencies now face as they try to modernize sensitive, high trust, and otherwise non-traditional service models without sacrificing usability, continuity, or confidentiality. One lesson that is modernization should begin with program reality, not technical abstraction. The team has to understand how the syringe exchange program actually functioned, what staff needed in the field, what privacy obligations were non-negotiable, and where legacy pain points were most damaging. A second lesson is that specialized public health workflows often require specialized design inside a broader standardized environment. The answer is not always to force everything into the same model, but neither is it to let every program remain permanently siloed. The strongest approach is often to build purposeful exceptions inside a sustainable enterprise framework. And yet a third lesson is that data migration, change management, and workflow alignment deserve as much attention as the software build itself. Public health systems succeed when the people, process, and the technology dimensions move together. And a final lesson is that better systems ultimately support better public health practice. Stronger privacy protections, better reporting, more consistent workflows, improved inventory tracking, and better information access are not just operational wins. They help agencies serve communities more effectively and respond more intelligently to emerging needs. For NACHO 360 and FICON audiences, we believe the central takeaway is that informatics modernization is most powerful when it is grounded in mission. It is shaped by frontline practice, and it is implemented through genuine collaboration. In settings like harm reduction, where trust, sensitivity, and public health impact are tightly intertwined, the decision of the information system becomes part of the service model itself. And that means that technology is not operating in the background as a neutral and administrative layer. It is actively influencing whether workflows feel usable, whether privacy feels credible, whether continuity is preserved, and whether the organization can turn daily operations into meaningful public health insight. And when we get that design right, we do more than just modernize technology. We give strength to the infrastructure that makes effective public health action possible, and we create a stronger foundation for trust, learning, and sustained service improvement over time. Corey and I thank you for your time and attention.